Welcome to the Deep Dive, where we sift through the most complex research to deliver the definitive insight you need. And today, we are undertaking a massive exploration into gout, a condition it's burdened by this massive historical misconception.
It really is. It's one of the most fascinating intersections of, history and biochemistry. For centuries, gout has been framed as the disease of kings,
Right.
a kind of moral failing that comes from a life of excess, too much port wine, too much red meat, all that luxury.
That image is so powerful, isn't it? The rich Victorian gentleman with his foot propped up on a stool, all bandaged, but it's so dangerously misleading. We're going to rip that image apart today because what we're actually looking at is not some rare historical anecdote. It is a rapidly accelerating global health crisis. The numbers are, frankly, startling.
They absolutely are. We've seen a dramatic surge, and not just in one country, but globally. The worldwide prevalence of gout hit 55.8 million people in 2020.
55 million.
And that's a 23% increase since 1990. To put that in perspective for those listening in the U.S., some estimates now place the prevalence as high as 17 million individuals.
That's about 5% of the entire population.
Exactly. This isn't a rare disease anymore. It's a common, often disabling condition.
So our mission today is to really move past that caricature and dive deep into the clinical reality. We need to unpack this entire journey from the invisible chemistry happening inside the joint.
All the way to the specific pharmacological strategies you need for long-term control. We'll cover the risks you can't change, the role of diet, comorbidities,
And the challenges of even getting a diagnosis right.
and, I think most importantly, the imperative of treating this condition not just symptomatically but aggressively, treating it to a specific biological target.
Okay, let's establish the fundamental biology right now. At its absolute core, what is gout?
Gout is a crystal deposition disease. The entire pathology, everything about it, hinges on the formation and deposition of monosodium urate crystals, MSU crystals. Think of it like a solution of salt water. If you keep adding salt, eventually you hit a point where the water just can't hold anymore, and the salt starts to precipitate out. It becomes solid.
So there's a critical chemical threshold in the blood. What's that limit for urate?
That threshold is defined by the solubility limit of urate in human plasma, and that number is approximately 6.8 milligrams per deciliter.
6.8.
Or 405 micromoles per liter for those who use that unit. When the concentration of urate in your blood goes above that limit, the risk of those MSU crystals forming just skyrockets.
And when those crystals form and deposit, that's the flare.
That's the flare. They trigger a massive, severe inflammatory response.
Okay, so that makes the connection between high urate, hyperuricemia, and gout seem pretty direct.
Yeah.
If your level is above 6.8, you have hyperuricemia, and so you have gout. Is it really that simple?
And that is the crucial diagnostic nuance we have to establish right up front. While hyperuricemia is a necessary precondition, you absolutely have to have high urate to form the crystals. It is not sufficient.
Meaning not everyone with high urate gets gout.
The vast majority of people who have hyperuricemia never actually develop clinical gout. We don't fully understand why, but many just never experience that crystal deposition event.
And to make diagnosis even trickier, what happens to that urate level during an acute attack?
This is such a classic pitfall, especially in the emergency room. A patient comes in, they're in the throes of this agonizing flare, but when you check their blood, the serum urate concentration can be misleadingly normal.
Why is that? Where did the urate go?
It rushed out of the bloodstream and concentrated into the inflamed joint space where it formed the crystals. So a normal urate level absolutely does not rule out an acute gout flare.
Let's shift gears now and talk about the history and really the dramatic rise of this condition. It's just wild to me that we've been observing gout for over 2 millennia. You have Hippocrates writing about it.
Right.
But the specific mechanism, the fact that it's driven by these MSU crystals, that was only definitively confirmed in the latter half of the 20th century.
It's very recent, clinically speaking. But what's so fascinating is that even though modern medicine understands the mechanism and we have really effective drugs, we are still seeing this marked, continued increase in both incidence and prevalence.
All over the world since the late 1970s.
Exactly. The question is why? When we know so much, why is this disease becoming more common?
Is it purely a diet issue? Is it just that we're eating more red meat and sugar?
It's more complex than just diet, though that's a big part of it. It's really a perfect storm of modern public health trends. First, increased longevity. People are simply living longer, and gout's prevalence increases significantly with age.
Okay, that makes sense.
Second, you have those significant dietary shifts globally. higher consumption of purine-rich foods, and especially excessive fructose.
And the third major factor seems to be the burden of all the other conditions people have, the comorbidities.
Precisely. Gout is strongly correlated with age-associated comorbidities like hypertension, chronic kidney disease, and diabetes. And it's a double whammy.
Yeah.
Not only do those conditions themselves increase urate levels.
But the medications we use to treat them.
Exactly. The very medications we use, things like diuretics for blood pressure, often affect the delicate balance of urate clearance in the body, driving levels up and triggering attacks.
Let's nail down some of those non-modifiable risk factors, the things you can't change. Starting with age.
Age is critical. The prevalence is significantly higher in older adults, soaring up to 10 to 15% in some populations. But the onset, it varies sharply by sex.
So.
For males, they typically see the biggest increase in incidence during their fourth or fifth decades of life, so in their 30s and 40s.
And for women?
It's substantially delayed. For females, the onset is usually in their sixth or seventh decades, so post-menopause.
And just a quick note on the lowest risk population, children.
Right. Gout is extremely rare in children, and this really reinforces that whole solubility concept. Their natural serum urate levels are low, maybe 3 to 4 milligrams per deciliter, which is well below that 6.8 threshold.
So what are the exceptions?
The rare exceptions are almost always due to significant underlying genetic issues. Things like inherited enzyme defects that lead to massive urate overproduction, or severe congenital problems with their kidney's ability to clear it.
The sex difference is really striking. You said males are affected about 3.3 times more frequently than females globally.
Yeah.
Can you elaborate on that hormonal protection women seem to have?
Yeah, it really comes down to estrogen. During a woman's childbearing years, estrogenic compounds enhance the urinary fractional excretion of urate.
So estrogen helps you pee out more uric acid.
Basically, yes. It acts as a mild uricosuric agent, helping the body flush it out. So after puberty, male serum urate levels naturally settle higher, around 5 to 6 milli-GDL.
And female levels stay lower.
They stay consistently 1 to 1.5 milligrams per deciliter lower than men's until after menopause. When that protective estrogen effect wanes, their urate levels begin to rise and approach those of men.
Wow. That one single hormonal difference just fundamentally changes the disease's trajectory for half the population. Are there specific ethnic or genetic predispositions we should be aware of?
There are, and we're still trying to understand all the variations. We've seen a notably higher prevalence among Asian American individuals, for instance. That group saw the largest prevalence increase between 2017 and 2018. And we also see these striking figures in specific endemic populations, like in French Polynesia, where the prevalence can be as high as 15%.
15%.
Or in the Taiwanese population, where it's around 6%. These are very high numbers.
And this all points to genetics playing a subtle but important background role?
Absolutely. We've identified many genetic loci, specific genes, that are associated with hyperuricemia. These genes are predominantly involved in regulating urate transport.
Where does that happen?
Mostly in the kidney controlling how much urate is excreted, but also, interestingly, in the gastrointestinal tract, which also plays a role in processing urate.
So your genes don't guarantee you'll get gout?
No, but they dictate the underlying level and efficiency of your body's urate balance. They kind of set the stage for whether you're likely to progress.
This progression, if it's left unchecked, it defines the natural history of the disease. Can you walk us through those 3 classic stages?
Certainly. In the absence of effective urate-lowering treatment, it follows a pretty defined, slow but destructive path. Stage 1 is asymptomatic hyperuricemia. High urate levels in the blood, but no clinical symptoms, no flares. And again, most people stay here indefinitely.
Okay.
Stage 2 is what marks the clinical start of the disease. Gout flares. This is the recurrent inflammatory arthritis, the acute episodic pain that people associate with gout.
And the final stage?
If the hyperuricemia remains uncontrolled and crystals just keep accumulating, you get to stage 3, chronic gouty arthritis or tophaceous gout. And that's characterized by persistent inflammation and visible tissue deposits called tophi.
What's the timeline for that unchecked progression? I mean, how quickly does that first acute flare turn into chronic disabling arthritis?
The timeline is a pretty sobering reminder of the disease's silent destructive power. The average interval from that first excruciating flare to the onset of chronic arthritis or detectable tophi is around 12 years.
12 years. Wow.
And that range is vast. It can be less than 5 years or as long as 40. But a decade of mismanagement is pretty typical for this severe progression.
And what happens if the patient just continues to ignore the underlying problem for decades?
Well, the outcomes get severe. The asymptomatic periods between flares, they get progressively shorter. The flares themselves change character. They go from being in one joint and resolving quickly
Like what?
to becoming polyarticular, affecting multiple joints at once. They become more prolonged, more and more disabling. After 20 years of untreated gout, almost 75% of patients will have developed clinically detectable tophi.
And the worse the urate level, the faster that happens.
Exactly. The rate of tophus formation correlates directly with how long you've had the disease and the degree to which your serum urate level was over that 6.8 threshold that whole time.
Let's dedicate some serious time now to the acute gout flare itself. For someone who hasn't experienced it, how do you even capture the sheer intensity of this event?
It's often described as one of the most severe pains a person can experience. It typically begins in one joint monoarticular, and the inflammation is immediate and just overwhelming.
I've heard patients say they can't even stand a bed sheet on their foot.
That is a very common description. The pain is so rapid onset and so intense that patients frequently report they cannot tolerate even the weight of a sheet or a blanket resting over the affected joint. They are desperate for relief. And the peak severity usually hits within 12 to 24 hours.
And the physical appearance of the joint, I assume it reflects that internal turmoil.
Absolutely. The affected joint displays intense redness, or erythema, warmth, and swelling, the classic signs of inflammation. And because the swelling can sometimes be so dramatic and extend well beyond the joint boundaries, it can unfortunately mimic a serious bacterial infection, like cellulitis.
I remember reading about dactylitis, the sausage digit.
That's a great descriptor for how it appears in the fingers, where the entire digit just swells up. And while it's primarily a local event, in some uncommon cases, that intense inflammation can trigger systemic symptoms.
Like a fever.
Fever, chills, a general feeling of malaise. And this combination of signs is what often raises the immediate alarm for a true infectious process, like septic arthritis or even bacteremia, which necessitates a very careful differential diagnosis.
What's so deceptive about this natural history is that those earliest flares, they do resolve on their own.
They almost always do. Even without any medical intervention, they'll resolve within a few days to several weeks. A common sign that the attack is finally subsiding is skin desquamation. The skin over the joint starts to peel or flake.
But that's the danger, right?
It's perhaps the greatest enemy of successful long-term treatment. The patient feels completely normal again, they assume the problem is gone, and they ignore the underlying fact that MSU crystals are still sitting in that joint, accumulating, and just getting ready to launch the next attack.
When we talk about location, does gout have a favorite spot to strike first?
It is highly preferential to the great toe initially. At least 80% of initial flares involve a single joint, and in the overwhelming majority of those cases, it's the base of the great toe, the first metatarsophalangeal joint.
That's podagra.
We call that specific localization podagra. It's the classic presentation.
Where else does it show up, especially as the disease progresses and becomes recurrent?
While podagra is classic, recurrent flares frequently hit the knee, the ankle, the instep or midfoot, and occasionally the prepatellar bursa, what people used to call housemaid's knee.
And less common sites.
Less common locations include the small finger joints, the wrists, the elbows, and the olecranon bursa at the tip of the elbow. It's interesting that when gout affects the finger joints, it's often seen in patients who already have underlying osteoarthritis. Sometimes it'll even appear right inside a Heberden or Bouchard nodule.
And what about those truly rare and frankly terrifying locations you mentioned earlier, the axial involvement?
Right, axial gout is rare, and it usually signifies severe, long-standing tophaceous disease. It can affect the shoulders, hips, the sternoclavicular joints, and most concerningly, the spine.
The spine.
Particularly the lumbar region and the sacroiliac joints. When gout involves the spine, it can lead to severe neurologic signs like radiculopathy pain radiating down the leg, or even spinal cord compression, which is a surgical emergency. It makes the diagnostic picture extremely murky.
Let's talk triggers. So the patient is hyperuricemic, the crystals are there. What's at the straw that breaks the camel's back and destabilizes everything into a full-blown attack?
We know that flares are highly time-dependent. They are statistically most likely to develop at night and in the early morning hours.
Why then?
The prevailing theory links this timing to natural physiological changes during sleep. You have a lower nocturnal body temperature, which actually reduces urate solubility. You have relative dehydration, and you have lower circulating blood cortisol levels, and cortisol usually helps suppress inflammation.
And the specific external triggers. What can a patient do that sets it off?
They fall into a few broad categories. First, you've got massive physiological changes, things like joint trauma or injury, major surgery, significant dehydration, or metabolic states like starvation or ketoacidosis.
And then the classic lifestyle triggers.
The classic ones, yes. Alcohol consumption, and that's beer, spirits, and wine, they're all implicated. High purine intake from foods like red meat and certain shellfish, and excessive fructose consumption.
Can you explain that specific link between fructose and gout again? It's not just another sugar.
It is not. It has a unique metabolic pathway. Fructose intake rapidly increases serum urate because when it's metabolized, it actually accelerates urate production in the body and simultaneously reduces the kidney's ability to excrete urate.
So it's a double hit.
It's a double hit that pushes the patient quickly over that 6.8 threshold. It makes sugar-sweetened beverages a very potent trigger.
And what about medicinal triggers?
Medications that cause sharp fluctuations in serum urate are notorious. Diuretics, like furosemide, are a major culprit. Low-dose aspirin is another. And crucially, inconsistent use of the very medications intended to treat gout can also be a trigger.
So starting and stopping your allopurinol.
Exactly. Rapid changes, whether they're up or down, can destabilize those crystal deposits. Finally, systemic triggers like a vaccination or chemotherapy, which cause rapid cell death and a subsequent spike in serum urate from all that cellular breakdown, are recognized as potential flare precipitants.
Let's now look at the physical consequence of decades of this unchecked hyperuricemia, tophi.
Tophi are the visible, physical manifestation of chronic gout. They are these dense deposits of MSU crystals, often surrounded by inflammation, that appear in soft tissues, tendons like the Achilles, bursa like the olecranon, and of course in the joints.
And the classic spot is the ear.
They are particularly classic when found on the helix of the ear, yes.
How do you clinically tell a tophus from some other lump or nodule?
When a tophus appears on the ear, a key differentiating factor is that it's typically so dense that it should not transilluminate. Light won't pass through it easily, unlike, say, a cyst. The overlying skin can become paper-thin, almost translucent, revealing the underlying chalky yellowish-white color of that massive urate deposit.
And they can rupture.
They can. If these deposits rupture, they drain that thick, chalky fluid. And that can, though rarely, lead to persistent chronic ulcers.
We established that the average timeline to developing tophi is about 12 years, but you said they can sometimes appear without that long history of flares.
That's true, and it's an important point for diagnosis. While most patients have years of intermittent flares first, tophi can sometimes appear de novo, without a clear preceding history of acute attacks.
And that's more common in certain groups.
This pathway is more frequently observed in older female patients, in individuals with advanced chronic kidney disease, or in those who rely heavily on diuretics or long-term anti-inflammatory drugs.
And we have to revisit the danger of the intercritical period, that time between flares when the patient feels fine.
That is the period of silent destruction. Even when the patient is completely pain-free, MSU crystals are still continuously depositing and accumulating in the joints. This silent chronic deposition is what leads to the bony erosions that ultimately define chronic gouty arthritis and cause permanent structural joint damage. The absence of pain must never be interpreted as the absence of disease.
That brings us directly to diagnosis. Since the pain can mimic infection and the blood test can be misleading, confirmation is absolutely non-negotiable. What is the definitive gold standard?
The gold standard, the test that provides 100% specificity for the diagnosis of gout, is the direct visualization of MSU crystals.
You have to see them.
You have to see them. This requires a procedure called arthrocentesis, aspirating the synovial fluid from the symptomatic joint or bursa with a needle. This should be attempted in any intermediate or large joint presentation, provided there's an experienced provider available.
And once you have that fluid, how is the crystal identified?
We use a special tool called a polarized light microscope. The MSU crystals are easily recognizable under this scope. They are needle-shaped, and they possess a specific optical property known as negative birefringence.
Okay, can you simplify that technical term for us?
I can. Basically, when those needle-shaped crystals are aligned with the axis of the compensator in the microscope, they literally light up in a definitive bright yellow glow. That bright yellow needle is the definitive proof of gout. You see that, you know what you're dealing with.
Beyond the crystals, what does the rest of the synovial fluid tell you during a flare?
Well, the fluid itself will be highly inflammatory. You'll see a white blood cell count typically ranging between 10,000 and 100,000 cells per cubic millimeter.
That's a huge number.
It is, with a pronounced predominance of neutrophils. This level of inflammation is similar to what you might see in a septic joint, in a bacterial infection, which underscores why finding that crystal is so vital to rule out a life-threatening infection.
But aspiration isn't always feasible, right? The joint might be too small, or the clinic might not have the right equipment. What if the patient has a visible tophus?
A tophus is a direct source of crystals. A clinically apparent tophus can often be aspirated directly. You use a large bore needle, maybe an 18 or 20 gauge, because the material is this thick, chalky paste of MSU crystals. This provides a great alternative route to definitive confirmation.
If aspiration is genuinely impossible or it's inconclusive, that's when we have to rely on advanced, non-invasive imaging to try and see those crystal deposits.
Exactly. And ultrasonography is highly valuable here. It's affordable, it's accessible, and it provides real-time visualization right there in the clinic. We look for two specific signs that strongly support a gout diagnosis.
Let's unpack those key ultrasound features. What's the first one?
The first is the double contour sign, or DCS. This appears as a distinct hyperechoic linear density, a bright white line that sits right over the surface of the joint cartilage. It essentially shows the sheet of MSU crystals that have been deposited on the cartilage surface.
A layer of crystal on the cartilage? And the second feature?
The second is what we call hyperechoic cloudy areas, or HCAs. These are the larger tophaceous deposits you might find in tendons or in the joint space. They often look like ovoid, stippled, cloudy masses on the ultrasound.
How reliable are those signs? Can you hang your hat on them?
Their reliability definitely increases with the duration of the disease. The sensitivity of the double contour sign typically ranges from 60 to 83%, with a specificity up to 91%. For HCAs, sensitivity is a little lower. But importantly, if the patient has had symptoms for longer than 2 years, the accuracy of the ultrasound significantly improves.
Moving up the tech ladder, the gold standard of imaging seems to be dual energy computed tomography, or DECT. That seems to offer the highest confidence in a non-invasive way.
DECT is transformative for this diagnosis. It uses 2 different X-ray energy spectra to analyze the chemical composition of tissues, so we can identify urate deposits in and around the joints with extremely high precision.
And you can tell the difference between gout and pseudo-gout.
Critically, yes. It solves that differential diagnosis problem by distinguishing urate deposits, which it usually color codes green, from calcium deposits like those seen in pseudo-gout, which it color codes blue.
What are the performance metrics for DECT? How good is it?
Pooled data shows excellent performance, a sensitivity of around 89%, and a specificity of 91%. Interestingly, false negatives with DECT are most likely if the patient's symptoms have been present for less than 6 weeks. It seems to take a little time for the crystal volume to build up enough to be definitively detected.
Is DECT just for diagnosis, or does it have other uses?
No, its role is expanding into monitoring. DECT can actually calculate the total volume of MSU crystal deposition in the body. That measurable crystal burden is associated with future cardiovascular risk and the likelihood of future flares. So it's becoming a key tool for monitoring how well your rate-lowering therapy is working. You can literally watch the crystal volume shrink over time.
And what about MRI? Where does that fit in?
MRI's role is supportive, but not specific for gout. Its main strength is in differentiating gout from other severe bone or soft tissue pathologies, like a major infection or malignancy. But because the MRI findings aren't specific to MSU crystals, if there's a real concern for infection or cancer, you still usually need to get a needle in there and get a sample.
For clinics that lack all this advanced equipment, what about the clinical diagnostic rules, the shortcuts that can help confirm gout?
When crystal confirmation just isn't possible, clinicians can use validated scoring systems, particularly for a first-time monoarthritis presentation. These rules assign weighted points to various clinical features.
Can you run us through the key point assignments? What gets the most points?
High points are given for male sex, that's 2 points. A previous patient-reported arthritis flare, another 2 points. Involvement of the first NTP joint or podagra, that gets 2.5 points. And of course, a high serum urate level, specifically greater than 5.88 milli-GDL, gets 3.5 points.
Okay, so those are the heavy hitters.
They are. Then additional points are given for things like joint redness, rapid onset within 1 day, and comorbidities like hypertension or cardiovascular disease.
And what score makes you confident in a clinical diagnosis?
A total score of 8 points or more places the patient in the high probability category. In the study populations, that correlated to a prevalence of gout around 82.5%. Intermediate scores, say between 4 and 8, really necessitate further investigation.
We've stressed that gout looks a lot like infection. What are the key things in the differential diagnosis we absolutely must rule out?
The primary confusion points are other forms of inflammatory and crystalline arthritis. First and foremost, you have to distinguish gout from calcium pyrophosphate crystal deposition disease, or CPPD, often called pseudogout.
And the microscope is key there.
The microscope is the definitive differentiator. CPPD crystals are rods or rhomboidal in shape, and they display weakly positive birefringence, the opposite optical characteristic of the negatively birefringent needle-shaped MSU crystals. Also, if you see linear calcifications on an X-ray, what we call chondrocalcinosis, that should strongly raise your suspicion for CPPD.
And what other types of arthritis can look like gout?
Well, you have to consider psoriatic arthritis or other spondyloarthritis, especially when gout presents in the fingers looking like that sausage digit or dactylitis. And it's crucial to remember that hyperuricemia is common in psoriasis patients, so the two conditions can easily coexist.
What about rheumatoid arthritis?
RA is another consideration, but RA is typically synchronous and symmetrical, affecting the same joints on both sides of the body at the same time. The features suggesting gout over RA include asymmetry, asynchrony of joint involvement, and of course, finding those MSU crystals.
Let's pivot now from diagnosis to management, starting with the non-pharmacologic strategies. I think it's critical to establish the role of diet and lifestyle changes right away. Where do they fit in?
The foundational point here is that non-pharmacologic strategies are always adjunctive. They are essential for improving overall health and managing those comorbidities we talked about, but they are rarely sufficient on their own to get the serum urate level low enough to dissolve crystals in a patient with established disease.
So medication is the main tool.
Pharmacotherapy is the engine. Lifestyle changes are the necessary fuel efficiency that makes the whole system run better.
And that engine requires patient adherence, which really has to start with good education.
Absolutely. Education is the first line of defense against poor adherence. Clinicians need to talk to patients in a sensitive, non-judgmental way and really address that classic misconception that gout is a self-inflicted punishment for a rich diet.
Right. You have to explain the genetics, the kidney's role.
The role of their other medications. And the best time to implement intensive lifestyle changes, like a rigorous weight loss program, is during that asymptomatic intercritical period, not when they're in the middle of a painful flare.
Let's tackle the comorbidities, starting with obesity.
Obesity and even just simple weight gain are significant independent risk factors for incident gout. Adiposity increases inflammation and complicates the body's ability to clear urate. So the goal in counseling should be gradual weight loss.
Not a crash diet.
No, aiming for a sustainable 3 to 5 pounds per month towards an ideal body weight. Studies clearly show that weight loss exceeding about 10 pounds in men significantly reduce their risk of developing gout in the first place.
And what about bariatric surgery?
Bariatric surgery has demonstrated success in reducing both the incidence and the severity of gout. We see substantial serum urate reductions within just 3 months postoperatively. However, starvation or any kind of rapid, severe caloric restriction can paradoxically induce a flare due to the sudden metabolic shifts. It's a delicate balance.
Hypertension is almost always there alongside gout.
It is a strong, independent partner of hyperuricemia. Primary hypertension dramatically raises the relative risk for incident gout, even when you account for the use of diuretics. So while successfully treating blood pressure is critical for cardiovascular health, the specific drug you choose to do it with matters greatly to gout management.
And what about managing diabetes in this population? Are there strategic choices there too?
We are seeing some very promising strategies here. While the data is still emerging, certain diabetes drugs appear to be protective. A class of drugs called SGLT2 inhibitors, used for type 2 diabetes, were associated with a lower risk of incident gout compared to sulfonylureas.
So they might even prevent flares.
It seems so. Meta-analysis evidence suggests patients taking SGLT2 inhibitors had a reduced risk of future gout flares, with a hazard ratio of 0.55 compared to placebo. This suggests that the choice of diabetes drug can and should be part of the overall gout management strategy.
That emphasis on drug choice leads us to the real minefield of medications that actively affect urate balance.
This is such a crucial segment for both providers and patients. Diuretics are the main problem, particularly thiazides like hydrochlorothiazide and loop diuretics like furosemide. They're independent risk factors for hyperuricemia because they interfere with urate clearance in the kidney.
But not all blood pressure meds are bad.
Not at all. Potassium-sparing diuretics like spironolactone do not share this risk.
So if a patient has gout and needs blood pressure medication, what's the best strategic choice?
When you're initiating or adjusting hypertension therapy, the priority should be to use agents that are either neutral or actively decrease urate, and avoid those that increase it.
Like losartan.
Losartan, an angiotensin-sensing receptor blocker, is a preferred choice because it has a modest uricosuric effect. It actively helps the kidney excrete urate, although this effect does plateau around a 50 mg/day dose.
What else is good?
Calcium channel blockers are also beneficial as they generally decrease urate levels and the risk of incident gout. Conversely, common drugs like beta blockers have been reported to increase serum urate, making them a less ideal choice in this patient population.
Let's tackle the controversy of low-dose aspirin for cardiovascular protection. Patients are often told to stop it if they have gout. Is that right?
That is generally poor medical advice.
Yes.
Low to moderate doses of aspirin, up to 3 grams per day, do increase serum urate and flare risk. However, if a patient requires low-dose aspirin for secondary cardiovascular disease prevention, it is critical that they continue it.
So you don't stop a heart medication for gout?
You do not. Instead, you must aggressively adjust the urate-lowering therapy to compensate for that increase, and you strongly advise the patient to take the aspirin daily to avoid the urate fluctuations that trigger flares.
Now to the traditional focus, dietary modifications. How effective is just reducing purine intake?
Diet plays an important supporting role. We definitely suggest reducing purine intake, particularly from animal sources like red meat and shellfish. High intake of these was shown to increase flare risk almost 5-fold in one analysis.
But is it enough on its own?
Rarely. While highly purine-restricted diets can modestly reduce serum urate, typically by about 1 mg/dL, this is often not enough to push a chronically hyperuricemic patient below that therapeutic target of 6 mg/dL.
Right. If you're starting at 9, dropping to 8 is better, but it's not a fix.
Exactly. And we need to clarify a frequent confusion point. The purine content in vegetables like green peas, spinach, or asparagus is much lower than in meat, and high intake of these vegetables is not associated with an increased risk of gout. Patients shouldn't be scared away from plant-based foods.
Alcohol seems to carry a much higher risk.
Substantially higher. All forms of alcohol, beer, liquor, wine are dose-dependently associated with an increased risk of incident gout and flares within 24 hours of consumption. Drinking more than 2 to 4 standard drinks had an odds ratio of 1.51 for causing a flare.
And what about sugar and fructose?
Counseling has to focus heavily on eliminating high-fructose corn syrup and sugar-sweetened beverages. As we discussed, fructose is metabolically unique in its ability to rapidly increase urate production and reduce renal excretion. Individuals with the highest fructose intake had a significantly higher risk of incident gout.
But diet soda is okay.
It is important to note that diet soft drinks, which use artificial sweeteners, were not associated with an increased risk.
Given the limitations of just restricting single foods, what's the advantage of promoting a whole diet approach?
Whole diet approaches like the DASH diet or the Mediterranean diet are highly advantageous because they tackle both the urate level and the related comorbidities simultaneously. These diets emphasize fruits, vegetables, whole grains, and low-fat dairy.
And do we have good evidence for their success?
The DASH diet, for example, has shown excellent results with a mean serum urate reduction of up to 1.3 mg/dL. And that benefit was even more pronounced in patients who started with very high baseline urate levels. High adherence to a DASH pattern was associated with a lower risk of getting gout.
Finally, what about those specific foods people always ask about, like cherries or coffee?
The evidence here is supportive, but, it's limited. Low-fat dairy products are strongly associated with a decreased risk of incident gout and lower urate levels. We're talking nearly a 50% lower risk in the highest consumers versus the lowest.
And cherries?
Cherries, or cherry extract consumption over a 2-day period, was associated with a lower flare risk, with the benefit stabilizing after about 3 servings. And high coffee intake, 4 to 5 cups daily, was associated with a lower risk of incident gout, though the effect is pretty modest in patients who already have the disease.
And what about exercise?
Exercise is universally beneficial for overall health, weight management, and comorbidities. While there's no strong direct evidence that exercise specifically reduces gout risk or flare frequency, its role in controlling obesity and supporting general health makes it a necessary component of any treatment plan.
We've established that lifestyle adjustments are supportive, but now we're diving into the pharmacologic imperative, the core strategy for achieving long-term remission. This is a game of aiming for a specific number.
It is entirely about hitting that number.
Right.
We call it the treat-to-target strategy. Because gout is a threshold disease, urate-lowering therapy, or ULT, is necessary to achieve long-term maintenance of subsaturating urate levels.
So you have to get it and keep it below the threshold.
You have to drive the urate concentration well below that 6.8 milli-GDL solubility limit. That's the only way to prevent new crystals from forming, and crucially, to dissolve the existing crystals that are silently accumulating in the joints and soft tissues.
So who needs to start lifelong ULT? What are the main indications?
We have pretty clear indications. Patients require ULT if they have frequent or disabling gout flares, often defined as 2 or more flares per year, or if they have any visible or radiographic evidence of tophi or structural joint damage. Or finally, if they're classified as high risk, say, they have a very high baseline serum urate, early onset disease, or a known genetic urate disorder.
What is that target level we're aiming for in the general gout patient?
The general and widely accepted therapeutic goal is a serum urate less than 6 milligrams per deciliter. That provides a safe buffer below the saturation point.
But if the patient has tophi, you mentioned the target is even more aggressive.
Yes. If a patient has tophi, structural damage, or just severe persistent disease, the target is tightened to a serum urate of less than 5 milligrams per deciliter. That lower level dramatically speeds up the dissolution and resolution of those physical tophaceous deposits.
This sounds incredibly rigorous. Does this treat-to-target approach actually work better than what's usually done?
The evidence is overwhelming. Randomized trials have shown that when care focuses rigorously on individualized education and regular urate monitoring to titrate medication, the treat-to-target approach success rates just skyrocket.
What kind of difference are we talking about?
In one key trial, 95% of patients in the target group achieved the goal, compared to only 30% in the usual care group. And this translated directly into fewer flares and greater resolution of tophi. It proves that aggressive execution is the key.
If a patient achieves that target of less than 6, how often do we need to keep checking their levels?
Monitoring is mandatory for success. When a dose adjustment is made, we test the urate 2 to 4 weeks later. Once the goal is consistently achieved, we confirm stability at the 3-month mark. If the patient remains stable, testing every 6 months for the first year, then annually is usually sufficient.
A common question we get is there a level that's too low? Is it dangerous to push the urate down to, say, 3 or 4 milli-GDL?
That's a great point, and the data is very reassuring. There is no established lower limit of safety for serum urate. We use agents like pegloticase in severe cases, which can drive urate down to unmeasurable levels, and clinical trials have shown no adverse neurological or cardiovascular consequences. The risk is all on the high side, not the low side.
Let's talk about the timing of initiation. If a patient is in agonizing pain from a flare, when should the physician start the urate-lowering drug?
The long-established conventional wisdom is to delay. We generally wait until at least 2 weeks after the acute flare has fully subsided before initiating ULT.
And what's the clinical rationale for delaying? Why wait?
There are 2 main reasons. First, there's a concern that initiating ULT during an acute inflammatory period could actually worsen or prolong the inflammation. Second, as we noted, 25 to 40% of patients have those misleadingly normal urate levels during a flare. Waiting allows you to get an accurate, true baseline urate level to guide treatment.
But I know there's a growing consensus that supports starting it right away in some cases.
There is. The argument for starting the drug right away, even in the middle of a painful flare, is purely pragmatic, especially for patients who have persistent, recurrent flares.
You seize the opportunity.
You seize the educational moment. Small trials suggest that immediate initiation, when combined with aggressive anti-inflammatory co-therapy, result in no significant difference in pain scores or the rate of subsequent flares. For a patient who is rarely flare-free, waiting 2 weeks might mean waiting forever.
Regardless of timing, flare prophylaxis is absolutely essential during that initial period of ULT. Why is that?
Because the very act of rapidly lowering the serum urate level, which starts to dissolve those old crystal deposits, can destabilize them. And that can trigger a new acute flare. So we have to use anti-inflammatory prophylaxis to bridge this period safely.
And the drug for that is colchicine.
Low-dose colchicine is the recommended agent through 0.5 to 0.6 milligrams once or twice daily, with mandatory adjustments for anyone with reduced kidney function.
How long does the patient need to stay on this preventative therapy?
For patients without tophi, prophylaxis is required for at least 3 months, and often up to 6 months, after starting the ULT. If the patient has advanced tophaceous gout, the crystal burden is much higher, so the duration is extended, typically 6 to 12 months.
And this brings us back to the giant hurdle we have to discuss: adherence. This is lifelong treatment for a disease that is, for most of the year, asymptomatic.
Non-adherence is the primary reason for treatment failure and disease progression globally. The treatment must be long-term, potentially lifelong. Patients frequently stop taking their medication when they feel well because they believe they're cured. We have statistics showing that compliance with a drug like allopurinol can be less than 20%. The disease progresses not because the drugs don't work, but because patients don't take them consistently.
Let's shift into the mechanics of the drugs themselves, starting with the first-line choice. The xanthine oxidase inhibitors, or XOIs, allopurinol and febuxostat.
These are both fundamental. They inhibit the enzyme xanthine oxidase, which is responsible for synthesizing urate. By blocking this step, you dramatically reduce the body's total production of uric acid. Allopurinol is the preferred first-line agent, just based on its long history of safe and effective use.
My understanding is that historical practice often led to underdosing allopurinol out of caution. Is that still a problem?
It was, and it remains a massive problem contributing to treatment failure. The strategy has to be start low, but go slow and go high enough. We typically start at 100 milligrams daily for someone with normal kidney function.
Hey, you don't stay there.
You don't stay there. The key is the titration schedule. The dose must be increased by 100 milligrams every 2 to 4 weeks until that crucial urate target of less than 6 is achieved. And the sources are very clear. Contrary to outdated practice, the majority of gout patients require doses exceeding 300 milligrams a day. Doses up to 800 milligrams a day are approved and often necessary.
And if the patient has chronic kidney disease, how does that titration strategy change?
CKD complicates allopurinol use because its active metabolite, oxycurinol, has a prolonged half-life, which increases the risk of toxicity. So the starting dose must be dramatically reduced. The rule is no more than 1.5 milligrams per milliliter per minute of estimated GFR.
So for a patient with an eGFR of 30, that's only 45 or 50 milligrams to start.
Exactly, a very low dose. And while you must titrate slowly, no more than 50 milligrams every 4 weeks, it's vital to understand that you are still trying to reach that therapeutic goal. The common failure is reducing the dose, but then stopping the titration prematurely, leaving the patient hyperuricemic and unprotected.
What's the most serious risk with allopurinol, and what can we do to prevent it?
The most serious risk is the development of severe cutaneous adverse reactions, or SCARs. This includes the life-threatening Stevens-Johnson syndrome. While it's rare, the risk is significantly higher in certain populations.
So we screen for it.
We must. Specific genetic screening for the HLA-B5801 variant is mandatory for patients from high-frequency groups. This includes Chinese, Thai, Korean, Filipino, and African-American or African individuals. A positive test result is a definitive contraindication. You cannot use allopurinol in that patient.
And what about the drug interaction with immunosuppressants?
This is a major concern, particularly in transplant patients. Allopurinol potentiates the toxicity of azathioprine and 6-mercaptopurine. Allopurinol should generally be avoided in these patients, or the doses of the immunosuppressants must be drastically reduced, which requires extremely careful monitoring.
That leads us to febuxostat, the alternative XOI. How does it compare in terms of efficacy and dosing?
Febuxostat is a non-purine analog, so it's chemically distinct from allopurinol. It's highly efficacious. The starting 40 milligram dose is roughly equivalent to 300 milligrams of allopurinol. It's usually titrated up to 80 milligrams daily if the target isn't reached. A key advantage is that it maintains high effectiveness even in patients with mild to moderate kidney impairment.
But this is where we run into the major controversy: the cardiovascular safety data surrounding febuxostat.
This is a complex area that really highlights the challenges of post-marketing surveillance. Early clinical trials hinted at a higher rate of thromboembolic events with febuxostat. This led to a large mandated post-marketing safety trial called the CARES trial, conducted in high-risk cardiovascular disease patients.
What did the CARES trial find?
The CARES trial did not find a difference in the primary composite cardiovascular endpoint between febuxostat and allopurinol. However, when the individual outcomes were analyzed, febuxostat was associated with an increased risk of cardiovascular mortality and all-cause mortality, with hazard ratios of 1.34 and 1.22 respectively compared to allopurinol.
That's a significant finding. It must have changed clinical guidelines.
It did. The FDA subsequently advised that febuxostat should be reserved for patients who have failed or do not tolerate allopurinol, and providers must counsel patients explicitly about this potential cardiovascular risk.
But the clinical waters are still murky, aren't they? There was another trial.
They are very murky. A subsequent, very large European safety trial called the FAST trial was conducted, and it failed to confirm the increased cardiovascular risk seen in CARES. So this created significant clinical uncertainty, leaving physicians with conflicting large-scale data.
If XOIs are contraindicated or just aren't enough, we move to the uricosuric drugs. Who is the ideal candidate for this class?
Uricosuric drugs, like probenecid, are the clearance agents. They work by inhibiting the reabsorption of urate in the kidney's proximal tubule, thus increasing renal clearance of uric acid. This makes them specifically suited for the 85 to 90% of hyperuricemic patients who are classified as renal underexcretors.
And what are the absolute contraindications? Who should not take these?
Since they dramatically increase the amount of uric acid flowing through the urinary tract, they must be avoided in any patient with a history of nephrolithiasis kidney stones, or those at risk of uric acid nephropathy. They just increase the likelihood of stone recurrence.
And what are the drawbacks of probenecid?
Probenecid requires multi-daily dosing starting low and titrating up to 3 times a day, which is a huge barrier to long-term adherence. And its efficacy is significantly reduced in patients with moderate to severe kidney function impairment, which are often the patients who need it most.
Finally, let's discuss the option for refractory gout, where oral agents have completely failed. Pegloticase.
Pegloticase is a highly specialized and powerful tool. It's a recombinant uricase enzyme that converts urate into allantoin, a far more soluble product. It's reserved for patients with severe, advanced, or treatment-refractory gout.
And this drug achieves a rapid and profound urate reduction.
It does. It's administered via intravenous infusion every 2 weeks, and it drives serum urate rapidly to very low, often unmeasurable levels. The goal is to rapidly dissolve massive tophi and restore joint function.
And why is immunosuppressive co-therapy like methotrexate mandatory for its use?
Because pegloticase is a foreign protein, the patient's immune system quickly develops anti-drug antibodies. These antibodies neutralize the drug's effect and greatly increase the risk of severe infusion reactions.
Methotrexate prevents that.
Weekly oral methotrexate dramatically improves the response rate from about 39% up to 71% and simultaneously reduces the rate of infusion reactions from a dangerous 31% down to just 4%. It's an essential part of the regimen.
And how do clinicians know if the treatment is failing because of these antibodies?
They monitor the pre-infusion urate level. If that level rises above 6 mg/dL, it's a clear signal that the patient has developed neutralizing antibodies and the drug has lost efficacy. Treatment must be immediately discontinued as the risk of a severe, potentially life-threatening infusion reaction is now sharply elevated.
Let's dedicate our final segment to special populations, starting with gout management in advanced chronic kidney disease. This is a patient population with high urate levels and an inability to process the drugs we use to treat it, a real catch-22.
It is the ultimate clinical challenge. Not only are CKD patients prone to gout, but the clearance of key drugs, allopurinol, its metabolite oxypurinol, and colchicine is reduced, dramatically increasing toxicity risk. And to make matters worse, the primary agents for treating the acute flare, NSAIDs, must be completely avoided.
Because of the risk to the kidneys.
Exactly, the risk of accelerating renal failure.
How does that affect prophylactic dosing with colchicine?
You have to dramatically reduce the dose. For prophylaxis in patients with a creatinine clearance between 10 and 34, the dose might be as low as 0.6 milligrams every 2 or 3 days. And critically, colchicine is entirely contraindicated in patients with stage 5 CKD who are on dialysis.
And for allopurinol and CKD, you mentioned the danger of under-titration?
Yes. We start with that severely reduced dose, and while we titrate very cautiously, 50 milligram increments every 4 weeks, the critical mistake is failing to continue that titration until the 6 mg/dL target is reached. Clinicians, fearful of toxicity, often stop titrating at 100 or 200 milligrams, which guarantees treatment failure. The patient remains hyperuricemic, the crystals keep depositing, and the disease progresses.
Is febuxostat an easier strategy for these patients?
For patients with moderate to severe CKD, so an eGFR between 15 and 50, febuxostat is often preferred. Its efficacy and safety profile hold up much better than allopurinol in that population, making it a more reliable tool to hit that target.
Let's talk about organ transplant recipients who face really complex pharmacological challenges.
Transplant patients are inherently at high risk for accelerated aggressive gout. This is largely because they receive calcineurin inhibitors, like cyclosporine or tacrolimus, which actively impair the kidney's ability to excrete urate. This often leads to the accelerated development of chronic tophaceous gout.
So the interaction with their immunosuppressants has to be managed extremely carefully.
Absolutely. The need for ULT often collides with the need for immunosuppression. You have to delicately navigate the interactions between XOIs and agents like azathioprine or 6-MP. Furthermore, these patients are at an increased risk for myopathy, or muscle disease if they take colchicine alongside cyclosporine.
We focused on drug management, but when does gout actually require a surgeon?
Surgery is rare, and it's strictly limited to managing the complications of tophaceous disease, not treating the underlying urate imbalance. The most frequent indication for surgery, about 51% of cases, is an infection of a tophus. Other indications include mechanical complications, like nerve compression from a tophus, or even spinal cord compression, which requires prompt surgical decompression to prevent permanent damage. And sometimes it's for intractable pain or severe joint deformity.
And there's a critical technical pitfall associated with surgical intervention, especially when a biopsy is taken.
This is a point that needs to be communicated to pathologists. Permeative bone lesions caused by gout can be radiographically mistaken for osteomyelitis, a bone infection, leading to unnecessary excisions or even amputations.
So how do you prevent that?
If a biopsy is taken to confirm the diagnosis, it must be handled correctly. The tissue has to be examined quickly or fixed in alcohol. If the sample is fixed using standard formalin, the formalin will actually dissolve the MSU crystals, rendering the biopsy non-diagnostic and perpetuating the confusion.
We've established that effective, targeted long-term ULT is transformative. It can virtually eliminate severe outcomes, like chronic arthritis and tophi are. So what drives the progression we still see today?
Progression is a management failure, not a drug failure. When we see patients progress to severe outcomes, like the development of polyarticular gout, which we often see in older women with comorbid osteoarthritis and diuretic use, it is almost universally linked to one of three things.
What are they?
Non-adherence, inadequate dosing, the failure to titrate to the target urate level, or the continued use of interfering medications due to insufficient comorbidity management.
And the prognosis is clearly linked to that initial crystal burden.
It is, and we can now quantify this. The overall urate burden, which can be measured precisely by DECT crystal volume, is directly associated with the likelihood of achieving gout remission. If you start with a high crystal burden, remission takes longer. But the core prognosis is excellent for any patient who adheres rigorously to a goal-oriented treatment plan.
So this deep dive has shown us that gout is a condition defined by a biochemical threshold. When serum urate concentrations cross that 6.8 mg/dL limit, MSU crystals precipitate, and that leads to intense pain and silent chronic joint damage.
And the path to diagnosis has to be definitive, either confirming those specific negatively birefringing crystals with a needle, or non-invasively visualizing the deposits using advanced imaging like ultrasound or DECT. Management is a lifetime commitment. It relies on a strategic dual approach. Strict avoidance of high-risk triggers like alcohol and fructose, combined with aggressive, targeted pharmacologic reduction.
The ultimate strategic takeaway has to be the imperative of the treat-to-target approach. We learned that the progression of gout to chronic disabling arthritis is primarily driven by systemic failures, either patients stopping the medication when they feel well, or the provider failing to titrate the dose of drugs like allopurinol sufficiently to reach that subsaturating goal of less than 6 or less than 5. The medicine works. The management must be rigorous.
Which leaves us with a truly profound question, doesn't it? We have the sophisticated chemistry, the diagnostic imaging, and highly effective drugs, XOIs, uric, even pegloticase, that can reliably resolve visible deposits and achieve remission. We know the exact serum urate level that solves this disease. And yet, global rates continue to climb, and non-adherence is the #1 obstacle. Doesn't this force us to question whether medicine needs to look beyond the prescription pad to address the deeply entrenched behavioral, educational, and systemic barriers that prevent millions from achieving lifelong remission from this ancient yet wholly treatable condition?
That's a powerful thought to consider as you reflect on this complex condition. Thank you for diving deep with us. We'll see you next time.